Welcome to my presentation on When is Medical Treatment Futile? My name is Terrence Shenfield, and I have been an education coordinator for the last 30 years at a major trauma center. This lecture is ethical in nature and will explain all about futile care. I'd like you to meet John. John is an immigrant from Italy. He came to this country when he was 5 years old. He raised a family of 3 children, put them through school, and later years of his life he got sick. So this is a story about John and how his family supported him and what they could do for him. So John was admitted to the hospital post-code, and he had a anoxic brain injury. After being on a ventilator for X amount of time, he ended up getting trached, and as a result of being in the ICU for a long period of time, eventually went into multi-organ failure, actually was starting to have seizure disorders, and being on a bed all the time resulted in decubitus ulcers. He was kept alive through a peg that gave him nutrition and hydration. Now, the truth be said, he could be kept on mechanical ventilation with artificial nutrition, artificial hydration for months. But the physicians felt that his age, 88 years old, and with his comorbidities, that everything they're doing is futile, that the likelihood of John coming off the ventilator, walking out of the ICU with any kind of meaningful life was absolutely nothing. So this is a story about the team felt one way and the family felt another. So John had 3 children, and his oldest daughter was actually the power of attorney. And she had 2 other siblings who were younger than her, and they had different opinions. For example, the oldest daughter, who was the power of attorney, felt that everything should be done for her father. She believed that in miracles. She believed that her father was going to get better. He's a strong man. Yet the other 2 siblings in the family felt that life support should be withdrawn, that the father had a good life. He's 88 years old, and he did a good life, and based on the physician's feedback to them that he wouldn't come off the ventilator and his life would be meaningfulness, they were in agreement with the physician. So the problem was, and is, must the treatment team maintain treatment they judge to be medically futile? So in other words, does the doctor have to maintain the patient on ventilatory support with artificial hydration and nutrition and be kept alive, even though they felt that the patient was not coming off the ventilator anytime soon? I have some questions to share with you, and I'm hoping that you might be able to think about it and maybe type an answer in your questions and answers. My first question: should the doctor try to convince the oldest sister to consider palliative care? The physician and the team felt that this patient was not going to benefit from being on mechanical ventilation, and the likelihood of them coming off the ventilator and having a meaningful life was very low. So they wanted to do palliative care. But it's up to the sister. So the second question: does the sister with the power of attorney's decision to refuse to stop treatment trump all other siblings' decisions? So the question here: yes, the older sister is the power of attorney, and even though her other siblings who are not the power of attorney, but they are the child of that father, do they have any right here? Do they have any legal right? Or does this older sister trump their decision processes? That's the second question. Third question: should physicians' personal beliefs and practices play a role in the end-of-life care? So all of us have our own perspective on end of life and quality of life. So should the physician's personal beliefs and practice play an important role in this? What do you think? And finally, what can help bridge the gap between belief systems and conflict here? What can you do to resolve this dilemma? You have the physicians and the younger siblings on one side. You have the older sister on the other. What can be here to lessen this gap between what they think? I have another case study for you. This is a case of a 22-year-old accident victim who's been in a persistent vegetative state for several months, and she's been in the same state for months, and the family has insisted that everything possibly be done to keep the patient alive. As a healthcare team, as a professional in healthcare, what is your obligations? What are the obligations of the physician? What is the obligations of the nurse? What is the obligations of the respiratory therapist? Do we have to maintain this patient in this vegetative state forever? What is our role? What do we got to do? What exact obligations do we have regarding this patient? So these are some of the questions you need to ask, and I have a couple more slides. I'm going to get a little bit more detail into the situation. It is easy to realize that there's a lot of conflicts going on within the family. A lot of times, the mom, the dad, the siblings, the husband, or anyone else involved with the patient can be conflicting information. In other words, not everyone feels the same way. Some people in the family may feel it might be beneficial to just take them off mechanical ventilation or take them off of tube feeding and, let nature take its course. Where others feel like there's a miracle, like they're going to come out of this. They're going to come out of this. They're going to open their eyes and give them a big hug. You really don't know. So conflicts within the family members about withholding or withdrawing futile interventions is very common in these situations. So the idea is, as a healthcare member, you have to think about, do you think that any kind of intervention that you do for this patient is futile? In other words, what is the goal of treatment with this patient? I mean, is the goal just to keep them alive in a vegetative state, or is the goal they're going to get better? Are they going to get some kind of surgical intervention? Is actually the damage that their brain has, is it going to repair itself? You need to really understand what the goals are, and they should be clarified. So this happens all the time in cases of vegetative state patients, where you have disagreement amongst the family members about exactly what to do, and you also sometimes have disagreements within the healthcare team on what to do. So you really need to articulate exactly what are the goals of the family and what are the goals of the medical team. Are they going to benefit from this situation by, interventions, or are they expecting a miracle? These are tough questions that arise in this particular situation, and you really need to have some proper answers to come up with a good solution. So in these cases, you really have to have some clear goals, and you need to have a discussion with the physician, the family, and various members of the healthcare team. A lot of times, this is a process. People just don't accept that their family member or loved one will be taken off life support. So you really need to have a discussion with them about what are the goals, what is their expectations, and then you as a medical professional have to speak about the fact that some things are irreversible. A lot of times you need to bring in social workers, you need to bring in palliative care services, you need to bring in hospital chaplains, and even ethical consults, because in these particular cases, this is a very tough thing. Hospital chaplains can really give peace to people who are, spiritually unwrung. They're really upset about everything. They don't like the idea of end of life services. Palliative care can ease the suffering and make the people feel more comfortable about, everything like that. And, it's a process. It's a team effort, and you really need to work with everyone. And this is a process, and a lot of patients in these vegetative states need this kind of group support. I have another tough situation. Let's talk about irreversible respiratory disease. In particular, you have an elderly patient who's on in mechanical ventilation in the intensive care unit, and no matter what they do to get him off the vent, he doesn't come off the vent. He fails on the vent. So there's a general agreement amongst the healthcare team that this patient, if they weren't in the ICU and if they weren't on mechanical ventilation, the likelihood of surviving is really low. So the patient themselves is somewhat awake and alert, and they're concerned about, they're holding on to life the best they can, and they're concerned that if they get some kind of respiratory infection, that they potentially would die from it. So they request that antibiotics be given to them, and they also feel that if they go into cardiac arrest, that they want to be resuscitated. The question is, if the healthcare team feels that the likelihood of them surviving outside the ICU without all its intensive care treatment is not going to do anything unless they are in the ICU, what's the point of giving antibiotics? What's the point of resuscitating them? They're only going to be in the ICU for a long time. So some ethical questions come up, such as, should a distinction be made between interventions requested by the patient? Should you give the patient antibiotics? Should you give them CPR if they need CPR? Do they need to be resuscitated? How about the age of the patient? The patient could be really concerned. Patient's at 88 years old, and you really need to look at all these things. This particular case of the 88-year-old gentleman who's in the ICU on mechanical ventilation, this really illustrates the conflicts that can arise, those ethical conflicts regarding withholding or withdrawing futile interventions with the patient. For example, the patient really wants to be resuscitated if they go into cardiac arrest. They also want to receive antibiotics to prevent any kind of lung infection. But the healthcare team knows that they are in an ICU, and their likelihood of surviving outside the ICU is really low. They cannot be transferred to a facility with a long-term vent facility that is not an intensive care unit because they're unstable. They know the ventilator actually produces physiologic aspects of improving their oxygenation and ventilation. But, the goal of this team is they know this patient can't stay alive in the ICU unless they're on mechanical ventilation. So what do? Do you take the patient off mechanical ventilation? Do you honor their request and give them whatever they want? Healthcare costs a lot of money. Every day in the ICU costs a ton of money. But what's the value of someone's life? Is the patient, because they're older, they're 88 years old, that it don't matter? So there's a lot of things that really need to come into play. And this is like the idea where ethical consults come into play, where you need to make some unfortunate decisions about everything. The central issue in this case concerns the qualitative futility. So basically what that means is the patient's quality of life good in the ICU? Whose decision is that? I mean, if someone's in an ICU and it costs the healthcare system $2,000 a day, the quality of life is they're intubated, they're in an ICU, they're surrounded by people who are their healthcare team, but that's not family members. So the idea is, what do? Is it better to withdraw life support from them? Is it better to continue life support with them? What do? So these kind of decisions are ethical decisions that got to be made based upon the condition of the patient and there's a lot of things, and there's no right or wrong answer, but our healthcare system is broke, and we are just not an endless bucket of money. You know, it costs money to do that. And the more time you spend with a patient who has no likelihood of survival, that means you're taking time away from someone else who could survive. So there's just so many different factors going on with this that you need to consider. Today's objectives are: what is futile care? Describe some legal definitions. Describe who decides when treatment is futile. And then I'm going to talk about two important components of healthcare practitioners. And one of them is healthcare burnout, and the other one is compassion fatigue. When we deal with patients who are dying every day and people who are morbidly sick, we have a lot of pressure on us as healthcare practitioners. And burnout and compassion fatigue is two very important components that occur in our field. So when you look at this ad, you say, what's going on? The advertising says, no matter what, fight on. And this advertising is brought forward by USC University Hospital. What do they mean? What do they mean by no matter what, fight on? I think this leans into futile care. There are some hospitals and healthcare systems which will say that they will help your loved one survive no matter what they got to do, and they make promises that, in my opinion, they can't keep. But sometimes healthcare has become big business. I'm going to refer back to this advertising a little bit later. So, what exactly is medical futility? There is no general accepted medical definition of what futile care is. If one considers that the goal of medical care is to achieve a benefit above a certain minimal threshold, then futile care can be defined as care that fails to achieve that benefit. The sticking point, then, is not the definition of futility, but the definition of benefit. That is why the application of the word futility in the discussion of medical care is considered ethically hazardous, especially when the values of the physician and the patient don't match. In addition, the inexact and somewhat unpredictable nature of medicine makes it precarious endeavor to call a therapy futile. Unless someone says that in the past 100 cases a medical treatment has been useless, then maybe you would call that medically futility. Physicians should distinguish between the effect, which is limited to some body part, and the benefit, which is limited to the capacity for a patient to appreciate. When you think about medical futility, we've all seen this in the ICU. We have seen patients who are intubated, who are up there in the years, who have the very small likelihood of coming off a ventilator or walking out of the ICU, and then they throw all kinds of medical procedures to this patient. I've seen this many times in my career. Medical futility can also be defined as life-sustaining interventions that have no medical benefit for the patient. Like, for example, why would you give someone a hip replacement when they're in stage 4 cancer? That might be considered futile care. Also, interventions and treatments that cannot end the dependence on intensive medical care. What that means is if you took someone off the ventilator, or if you stopped feeding them through a PEG system, then they would die. So medical futility is a hot topic. It's a very ethically challenged topic, and it really sometimes have patients and families fighting with each other. Let's talk about some legal and medical definitions of what futile care is. In regard to laws, state laws rarely define what medical futility is. They also don't describe what is ineffective care. The American Medical Association has a definition of medical futility. They call it care that offers no reasonable chance of benefiting the patient, but they don't tell you what reasonable is. Reasonable to me may be quite different than reasonable to you. So everyone has a different definition of it, and you can see this is a slippery slope that the American Medical Association takes. I'm going to give you some more definitions. The American Thoracic Society considers medical futility as treatment that is considered medically futile when it's highly unlikely to result in meaningful survival. Again, what is meaningful survival? Meaningful survival to you may be that you need to be able to play football 5 days a week. You need to be able to run around and get out of the house, where someone else might be meaningful survival could be sitting in a bed all day in your room watching TV. So what exactly is meaningful survival? The Society for Critical Care Medicine says physicians must be certain that an intervention will fail to accomplish its intended goal. I like that. I mean, if the goal is to improve the quality of life of the patient, that is good. But again, who establishes what is the quality of life of patients? Quality of life of one person can be quite different than quality of life of someone else. We have a couple of other definitions. One is called physiologic futility, and the other one is called imminent demise futility. In physiologic futility, the desired outcome cannot be met. It implies that there is no reasonable expectation based on scientific evidence that a physiologic outcome from the treatment can be achieved. An example of this would be a surgical procedure where a patient who has a Glasgow Coma score of 3 following an intracerebral bleed would be futile since spontaneous brain function could be restored and not to be a physiologic expectation. So in other words, you could do some surgical procedure, but the likelihood of them having a good brain afterwards is not there. So that's an example of physiologic futility. Imminent demise futility is you could do an intervention with the patient, no matter what you're going to do, the patient will die in the near future. It would be like doing a hip replacement on a 86-year-old person who has in stage 4 cancer. So yeah, you're going to do very well with the hip replacement, but the likelihood they're going to die in the near future is really there. So that's called imminent demise futility. There's so many definitions in medical futility. We're just scratching the surface, but I wanted to mention a couple more. There's a term called quantitative futility. And basically, this is a mathematical chance that you have less than a 5% chance of success to live. So this actually might be a very good way of doing things. You know, when someone is critically ill, especially a loved one, you want everything in your power to keep that person alive, even if it doesn't make medical sense. Our hearts believe that there will be a miracle that will make this person better. The likelihood of them getting better is probably very small. And when you think about the cost involved with taking care of patients at the end of life, it runs into so much expenses. So quantitative futility, which is a method some different countries use, suppose what they do is they have computer algorithms and they punch in the age of the patient, the diagnosis, comorbidities, and a bunch of other factors into this program. And what that will do is spit out a likelihood of survival. And if it's less than 5% of chance, they actually will do palliative care. And this eliminates emotions. It eliminates the fact that it's your dad or your mom or your brother or your sister, and it actually saves money at the end of life care. Another form of medical futility is called qualitative futility. And qualitative futility means that, you know, yes, you can survive. We could do X, Y, and Z on you, and you will survive, but your quality of life could be so poor. So, for example, suppose someone is in a major accident and they lost their vision and they amputated 2 of their legs. And yes, you could make them survive. You could patch them up and they will be bedridden and blind for the rest of their life. Is that quality of life? Is that how someone wants to live for the rest of their life? So that is called qualitative futility, is when you offer someone life, but the quality of their life could be very poor. The concept of medical futility is not modern. Actually, it goes back to millennium at the times of Plato and Hippocrates. Hippocrates believed that there are three major goals of medicine, and that is to cure, to relief of suffering, and the third one is what I want you to pay attention to: refusal to treat those who are overmastered by their disease, realizing that in such cases medicine is powerless. He knew that when it gets to a point, there's nothing else you can do, so just let it go. And Plato said it very well too. He says to attempt futile treatment is to display an ignorance that is allied to madness. So both of these wise men both agree that treating patients who are futile in their care is not where you want to be. So who decides when treatment is futile? I want to tell you a story. Danny was a 77-year-old executive from the government. He retired and he was diagnosed with COPD and prostate cancer for over 10 years. He was sent to the emergency room because he had pneumonia and heart failure. The doctor then transferred him to the ICU because he needed to be intubated and given support by mechanical ventilator and then some antibiotic therapy. Prior to intubation, the doctor told Danny that weaning from the ventilator may take longer than normal because of his COPD. And Danny understood this and agreed because his wife was not in good health and he could not take care of himself at home. So he made an indication that he wanted to be intubated. He understands it may take longer than normal. Danny also expressed that he did not want full CPR, so he wanted to be a DNR. Danny was intubated, placed on a ventilator, and put on a regular course of antibiotics for the pneumonia. As anticipated, he was a very difficult wean. The doctor transferred him to a respiratory ward because after 3 weeks in the ICU, he wasn't able to wean off the ventilator and felt that maybe in this respiratory ward they could do a better job. 12 days later, Danny told the nurses he strongly desired to be removed from the ventilator. So he's been on almost like a month and a half on a ventilator, and he wasn't weaning anytime quick. So he asked the nurses, can he be removed from the ventilator? So the doctor discussed the situation with Danny's wife, and he also spoke with the children. And he also told Danny that the cancer is not really getting any better and that the likelihood of a good survival is not really high. So Danny's wife and the children felt that they did not want to take him off the ventilator. They wanted to keep him on the ventilator. 10 days later, Danny told his wife that the cancer caused him pain and he had difficulty breathing, even with medications to relieve the pain. So he told his wife he's in pain, he's on a ventilator, he doesn't like what's happening. So according to things where he felt he was dying at this point. He also feared that experiencing shortness of breath, and he felt that he would rather just die in his sleep. Eventually, Danny and the doctor decided to withdraw ventilation. They actually did a terminal extubation, and he passed away within 24 hours. This situation happens all the time. So who makes the choice when someone's coming off the ventilator? Is it the healthcare provider? Is it the patient and their surrogates? Or is it the courts? There are some people who feel that it's their innate right, their autonomy, that they could choose what they want. So if you're on a ventilator and you choose not to be on a ventilator, this is your God-given right. And that's called autonomy. Sometimes people put together an advance directive. An advance directive could almost dictate exactly what you want and what you don't want in cases like this. So this is a very difficult decision to make for people. And one day, hopefully, none of us have to make this kind of decision. At end of life, there's a lot of questions, and I am sure you have all heard of the Terry Schiavo story. This was a legal issue that existed between the husband of Terry and her parents. and actually went through the court systems between 1990 and 2005. The decision was, should the feeding tube be removed from Terry? Terry was not on mechanical ventilation, but she was on a tube feeding. And without tube feeding, she did not eat and she would perish. So her parents felt that she was conscious, awake, and that she should continue with the tube feeding, where the husband felt differently. She was diagnosed by multiple physicians, including independent court-appointed physicians, and they all diagnosed her in being in a persistent vegetative state. They also did diagnoses by the parents and their physicians, but these physicians were hired by the parents, so you can imagine there was some kind of bias. Terry collapsed in her St. Petersburg home from cardiac arrest in February 25th, 1990. She actually suffered major brain damage as a result of lack of oxygen, and after 2.5 months in a coma, she was diagnosed as being in a vegetative state. For the next 2 years, doctors attempted speech therapy, physical therapy, and other experimental therapies with her to try to gain her state of awareness. You know, her eyes would be open, but she was really, the lights are on, but she's not really there. In 1998, her husband decided that he really wanted to remove the feeding tube because this is not what his wife wanted, and he petitioned the Sixth Circuit Court in Florida. And this was opposed by her parents. Her parents were named Robert and Mary, and they did not want this to happen. They felt that she was getting better, even though everyone knew differently, and they opposed the removal of the feeding tube. There were numerous court battles going back and forth, and really nothing was resolved. Finally, a court order demanded that they remove the feeding tube, and she died after that. So this started the whole premise of advanced directives, and actually it talks about, you know, futile care, how people make decisions one way or the other. It talks about, you know, maybe you should have advanced directives. And this sort of set a bunch of different laws in the law books that would how we move forward in the future. Let's talk about death and dying, the 4 paradigms. Some people look at death as a very natural part of life. You're born, you live, and you die. In America, there's a term called the medicalization of dying. What that means is that 70% of all Americans die in a hospital, a nursing home, or assisted living. Many times, the people who die don't have their loved ones around them. For example, when my mom died, she was in a hospital. I'm sitting in my office, and I got a phone call from the physician telling me that he has some bad news. I'm sorry to say that your mom passed. A lot of people are dying at home now, especially with the use of hospice. I think it's a very dignified way to go if you die at home. I actually know 3 people within my immediate circle, not family members, but my in-laws, where they died at home. They die in their own bedroom. They die with the people who they love around them, and they are surrounded by people. I know in my advanced directive, when I go, I'd rather die at home with the familiarity of my home and the people who I love. Some people die in hospice and palliative care. Palliative care has become very effective these days, and the use of hospice has become very effective. The East Coast, especially around New Jersey, Pennsylvania, and New York, has been slow to catch on to hospice. The West Coast has actually been very proactive about the use of hospice and palliative care, and we are just starting to catch up. I've seen my palliative care program at my hospital greatly improve over the years, and I'm sure you see the same thing. There's another concept called death on demand. Think of Kevorkian, and I have some few slides to talk about that a little bit later. While on the subject of the ethical concerns of dying and people's choice, there's a thing called an advance directive. An advance directive is a written document that explicitly tells exactly what you want done and what you don't want done And you do this while you're fully capable of making good decisions. So if, God forbid, you're ever in a bad car accident, or if you have a stroke and you can't speak for yourself, your advance directive can sort of dictate exactly what you want, what kind of care you want, what kind you don't want. And it's kind of funny. We're all healthcare practitioners. I'm sure all of us has seen death many times. We all have seen suffering many times. We all have seen patients, families fighting with each other about what's going to be done with the patient. We've seen families split apart from all this. And I always do a survey at my live conferences, and I ask how many of us, since we're all healthcare practitioners, nurses and respiratory therapists, how many in this audience actually have an advance directive? And you'd be surprised that only about 10 to 15% of the people in the audience have an advance directive. So I was thinking, why don't they have an advance directive? And I hear various reasons. They never got around to it. They're thinking about doing it. They think it's expensive, which it's not. And then I told them my reason for not having an advance directive. I seen death, I seen suffering, I seen pain. I know exactly what I want. And the reason I don't have an advance directive is because I feel I'm going to jinx myself. Can you imagine? Very scientific. I'm going to jinx myself if I sign it. Now, I found that most advance directives are really done as people get older, and they actually have some recurring bouts of going in and out of the hospital. It seems as someone gets older and they have chronic disorders and they're admitted to the hospital, if they're admitted like 2 or 3 times in 1 year, they start realizing about their mortality, and they start considering what an advance directive can do. And it could be really smart. You could sometimes save families from killing each other if you had an advance directive, and plus you could be treated the way exactly you want. So it's only used when you can't speak for yourself, and sometimes what you get is called a power of attorney. A power of attorney is someone who you're real close to, and it doesn't have to be your spouse, it doesn't have to be your sibling, it could be one of your best friends that knows everything about you. A power of attorney gives them the right to dictate what kind of care you want to have. And sometimes this resolves a lot of family issues. So I'm sure a small percentage of you have advance directives. I'm sure it's not like 60, 70%. But as we get older and we realize that we are not Superman or Supergirl, we just may end up getting it ourselves. So I have a good question for you. Can a healthcare provider, such as a doctor, refuse to give futile care to a patient? Can they say enough is enough? And the answer is yes in certain states. At the time I put this presentation together, Alaska, California, Delaware, Hawaii, Maine, Mississippi, New Jersey, New Mexico, Tennessee, Texas, and Wyoming all allow for a physician to refuse to give care to a patient they feel is futile. If they feel there's no possibility of them surviving, they can refuse. So all of them permit providers to refuse care if it's medically ineffective or medically inappropriate. Here's a caveat. The caveat, though, is that you may refuse to care for them, but you need to notify the patient or the patient's surrogate about alternatives. So in other words, you remember the slide I was telling you, no matter what, go on, keep on going. There are some hospitals that will take a patient who, in another physician's point of view, would never survive. The idea is that you got to keep the patient stable for the transfer. So there are hospitals out there and there are doctors out there who will promise to do everything for you. And as long as you pay them, they'll do whatever they can do. But the thing with the physicians in Alaska, New Jersey, Pennsylvania, and so on, is that they need to keep the patient in a stable condition upon transfer to that other institution. Kind of wacky, isn't it? So the question comes up, who decides when care is futile? Who decides that when whatever you're doing cannot really improve the outcome of this patient? And ideally, it should be made between the physician and the patient's family or surrogate. When you look at the effectiveness of treatment, that is really an objective measure based upon knowledge and expertise of the physician. So the physician is the sole person who could determine whether what they're doing is going to be effective because they use objective knowledge. In regard to the benefit, that typically falls on the patient or the patient's family or the surrogate. And that's subjective in nature. And that can be kind of difficult because it's easy to think in objective terms, but when you come down to subjective terms, that's where it gets very cloudy. The burden of this falls on the physician and the family for actually looking at scientific data, and if the family understands the scientific medical data. And it also could look at personal aspects of people's different personalities. You know, some families want everything done and have no clue when you say that the patient is brain dead and there's no cerebral activity. They just don't get it. So this is a very, very difficult role for both the physician and the surrogate. And remember, the physician should be basing their knowledge on expertise and science, where the family could base it on a balance of emotional benefit, financial, and social burden that falls on that. It's very difficult choices. To further this conversation, let's talk about how do you, as a healthcare practitioner, feel about working with patients who die in front of you? Do you think it has some kind of impact on you to see people suffer, to see families fight, to see heartache? Even decisions made by doctors and families you may not agree with. Your personal belief system could be impacted. And trust me, like you, me, everyone else who's involved with caring of the patients, we have our opinions. So they actually did a survey, and they looked at 759 nurses and 687 physicians, and they wanted to know about treating a patient who they feel is futile care. In other words, they feel that the care rendered to this patient is not going to improve the outcome of this patient. And 70% of them felt it went against their standards and conscience and treating futile patients. They did not agree with it. And 50% of them felt that withdrawing or withholding medical treatment is one of the biggest stresses of the job. So what do you mean by withdrawing or withholding medical treatment? And when you really think about it, when you do a terminal extubation, that is considered withdrawing life support. I have my own personal story. When I first became a respiratory therapist, I used to work with a hospital, and one of the patients that I was taking care of, who was on a Puritan Bennett 7200, this patient had some kind of neurological disorder where he couldn't move his body, but he was on mechanical ventilation. And when I went into his room, he had this immaculate room. And when I walked in there, his eyes went directly for me. He actually was a very handsome, dapper man. He actually used to wear like an English smoking jacket, and he had a trach, and he was on a Puritan Bennett 7200. And I got to know him, and I really felt like, I don't know what kind of quality of life he had, but he really looked well, and he was taking care of himself. So one day, about 3 or 4 weeks later, I got called up by the nurse manager, and I was a brand new therapist at this time, not much experience at all. And she calls me on the phone. She says, listen, I need you to come to the room where he is. I says, okay, I have a couple more treatments to do, and I'll be right there. She says, no, I need you now. And I thought she was kind of rude and very bossy to me, so I ended up going up there. And when I opened the door, she was right there, and she said to me, this is the nurse manager. She says, Terry, I want you to discontinue the ventilator. And I looked at her with my mouth open like I didn't get it. And she obviously saw that I didn't get it. She says, Terry, you need to remove the ventilator from the patient. The patient wants to be taken off the vent. And again, I was frozen. So she says, come in the room. So I walk in the room, and then when I walk in the room, instead of the patient being alone, there was about 12 different family members in the room, and everyone looked at me. And I looked at them, and then she nudged me toward the ventilator, and I disconnected the patient from the ventilator. As soon as I turned the ventilator off, I heard a squeal through the room of people crying. I almost freaked. But this was my first experience of seeing someone taken off a ventilator, a terminal wean, and it really, I remember that moment as of right now. I can sense just the way I felt. So it is very difficult to withdraw life support from a patient, and doctors, nurses, respiratory therapists, we all feel it. As a consequence of working in the ICU, of working with patients who die, of working with families who are suffering and crying, and patients who are suffering and crying, and working with coworkers who are very frustrated with everything going on, there's a couple of conditions that are unique to healthcare practitioners. One of them is called burnout, and the other one is called compassion fatigue. I'm sure we all know what burnout is. Burnout is the frustration, loss of interest, decreased productivity, and fatigue caused by working long hours. For example, burnout can be you working 12 hours a day up in an ICU, doing 4 or 5 transports, having everyone call for you at the same time, having your supervisor or your manager calling you down because they need your help in the ER. So you get burnt out from this. Healthcare practitioners end up leaving the field typically after 3 years. Either you're in there for 3 years or you're there for 30 years. So if you're not gone by 3 years, you're going to probably be there for 30 years. And another thing that it's called compassion fatigue. Compassion fatigue is that we always see pain in patient. We always inflict pain in patient. For example, when we do an ABG on somebody, or if we suction somebody, we're inflicting pain. And sometimes we see people who are in pain, we see people who are dying, we see people who are, bleeding, and there's so many different things we see. But to do our job effectively, we have to become we can't become empathetic to them. We have to sort of just do our job. And a lot of times we fail to react sympathetically to them in medical conditions. And this sometimes, due to the exposure of what we do, this is called compassion fatigue. Both of these conditions are not very good for healthcare workers like ourselves. Now, I'm sure that we all know what burnout is, and we probably know a lot of burnt out therapists, don't we? Burnout is characterized by personality changes. And what happens is when people are burnt out, they're typically withdrawn. They typically are kind of snappy and short-tempered. They typically look at everything from a negative perspective. And some people can tolerate this better than others. For example, if you're used to working in an intense situation up in an ICU, like I mentioned before, and you got 10 ventilators and you're running around like crazy, there's a lot going on mentally and physically at this point. Everyone has a different personality. Some people can tolerate this much better than others. Some people can just get the job done. They run from point A to point B. Even if the workload gets high and you get people who are snapping at you and you're working long hours, some people can resolve and be strong through this. But there are some people who cannot do this. I've seen burnout in the past. I've seen a few of my former colleagues who became burnt out on the job, and it became obvious to everybody. So basically, when you're looking at someone who's burnt out, they're characterized by emotional exhaustion, depersonalization. They feel that they're not accomplishing anything, and you know who they are. I don't need to explain who they are. And there's ways to resolve burnout. Resolve burnout is if you feel like you're part of a team, if you have a supportive management staff that understands you, they maybe rotate you from a high intense area to a lower intense area periodically. They try not to give you long hours of working where you're working like 6 shifts in a row or 12 hours a day. So, and also improving your environment. You need to have a safe environment to work. You can't have people snapping at you. So all these things could prevent burnout, but burnout is definitely a condition that we see in our field. Now, another condition we see is called compassion fatigue. Um, we are exposed to patients who go through pain and suffering. We are exposed to situations where family members are crying and are really upset. We have inflicted pain on patients, like I told you before. There's times when we suction a patient, we do an ABG, or if we help a nurse roll a patient who has a decubitus ulcer. You know, there's so many different things that are going on with patients. And to do our job effectively, we almost have to separate the pain and suffering they're going through. But some people, again, can't cope with that, and it causes stress-like symptoms. In other words, there's some patients, no, I take that back, there's some coworkers of yours who get very stressed during this time, and they have to develop some coping skills. Some people have coping skills better than others, just like burnout. You know, some people can handle adverse conditions, adverse people, adverse this and that better than others. So compassion fatigue is you lose empathy for the patient. You don't care about their suffering. You know, you just become numb, and this is not a healthy way to be. So what happens when doctors and patients disagree with each other? It happens all the time. We hear doctors trying to convince families of what's futile and what's not, about what care to give and what's not. Physicians are not obligated, either from a legal or ethical standpoint, to provide care that falls outside the standard of care. So if you have conflicts between families and doctors, the American Medical Association recommends a process resolution. And what that is you discuss with family and patients with a team, a committee. You could also speak to the ethics committee, or you could finally transfer that patient to another institution that will accept. Like I said, that original post, we do it all. That's your company that will accept these patients. That's the hospital will accept them. So it happens. There are disagreements between physicians and patients, and you need to have some kind of process resolution to deal with all that. So in summary, you should be aware of what futile care is. We see it every day, and it's not going to go away. You're going to hear about situations where procedures, diagnostics are being done on patients. You're going to see family fighting, but understand what futile care is. Sometimes you have to examine your own personal beliefs for you and your family. So if you ever see a decision in the future, you could apply your own personal belief systems in there. And another important thing is know your limits. Burnout and compassion fatigue is very prevalent in our work, and you'd be surprised how many people just go in, day out, day in, day out, and you'll recognize who they are. It's very obvious. And finally, as healthcare practitioners, we've seen suffering, we've seen death, we know what we want, and you may want to consider advanced directive in the future, and you may also want to consider a proxy for someone who could speak for you when you can't. All of these things create a healthy environment. I want to thank you very much for joining me at the presentation. I have some good references if you're interested. They will talk a lot about futile care, and especially geared toward the healthcare practitioner like you and me. And I hope you enjoyed this presentation. You take care.